It is great honor for me to have opportunity to make a presentation in KTRI. Sorry, I changed the title to Successful Bailout the Broken End of the Viperwire by using twisted wire technique. No COI. Atherectomy technique widely used to develop calcified regions can be effective in treating balloon uncrossable or heavily calcified regions, but required of use specialized guide wires. Broken guide wire is a rare complication of PCI. The reported incidence is 0.1%, usually occurs during PCI of severely and diffuse calcified regions. Catheter-based retrievals are generally preferred over surgical extraction. An 81-year-old female with hypertension and diabetes presented to our hospital complaining of chest discomfort. No remarkable findings in her physical examinations. Blood test, ECG, chest X-ray were almost normal. Her left ventricular ejection fraction was 55%, no asthenia, no valvular disease, and almost normal findings. Coronary angiography was performed with the diagnosis of effort angina. CAG demonstrated multiple vessel regions which were calcified in stent restenosis in the RCA, in proximal to middle of the LAD and middle of the LCX. DFR and FFR were performed for LAD. As a result, of DFR was 0.79 and FFR was 0.80. So we decided to perform PCI for LAD at first. This is a strategy plan. Puncture through the conventional radial artery and with a 6 French heart rate to SS 3.5 and crosses the Sion wire and performed IVAS run. If the calcified region seems to be strong, we will develop King system. After developing predilatation and the drug editing stents were deployed to regions. We carefully attempted to advance Sion wire to the LAD. Initial IVAS showed LAD had diffuse calcified regions. Due to severe calcification, we decided to use low ablation atherectomy to develop the calcified regions of proximal LAD. We inserted fine cross GT, successfully crossing the region and removed the initial Sion wire. Then rotor wire was inserted into the microcatheter. Rotor ablation with 1.75 millimeter bar at 200,000 rotations per minute was performed multiple runs, and it passed on the 16th rotor ablation. And when we finished rotor ablation atherectomy, we changed to the Viperwire by using microcatheter. Viperwire was inserted. Rotor ablation low speed run was initiated distal region to the middle of the LAD using a 1.75 millimeter bar diameter bag. And next continued with the low speed run at the proximal region of the middle LAD. When finished, we tried to change from the Viperwire to Sion wire, but at that time, fluoroscopy revealed a broken end of the Viperwire at the distal of LAD. Angiography was performed immediately. Fortunately, no vascular injury was observed, as the LAD blood flow was well preserved. Factanious removal of the broken end was immediately attempted. Most important challenge is to tightly hold the broken end. At first, the Sion wire was passed through the distal of the LAD, and then Sion blue wire. Finally, Renat wire. Even if holding the broken end succeeds, the retrieval of the broken end was still difficult. So we tried 3 times, but no success. We tried twisted about 20 times and tangled, and then we slowly peel back the twisted guide wires. As a result, the broken end was trapped by the twisted guide wires and pulled into the guiding catheter at the fourth try. Then we carefully pull back the guiding catheter and the guide wires together. Nevertheless, angiography showed no complications such as the vessel perforation or dissection. So we decided to continue with the intervention. A new Sion wire was then crossed the distal of the LAD, and second IVAS showed successfully in cutting and polishing the surface of the calcified regions. After the second IVAS examination, the middle LAD repeated dilated with a 2.5 30 mm squaring balloon. And next, proximal LAD was repeated dilated with a 3.10 mm squaring balloon. Then we deployed a 2.25 by 38 mm drug editing stent at the middle LAD. And next, deployed a 3.25 mm 38 mm same drug editing stent at the proximal LAD. This is a final IVAS. Generally good findings. Also, the middle stent is also partial pore expansion due to the calcification, but it was not observed about coronary dissections or perforations. These are final results. The procedure was completed with no complications. The contrast used 119 milliliter, and the procedure time was 156 minutes. After PCI procedure, we observed any barriers. The broken end of the Viperwire was twisted Sion blue and Rinat, and it was entangled. This is the broken end of the Viperwire. We successfully retrieved the broken end of the Viperwire by twisted 3 wires technique. If it can't be recovered, surgical treatment will be required, which means increasing the burden on the patient. For that reason, assuming such a case, we thought it was very important to learn several variant methods. Thank you for your attention.